Hi, this is Chris.
I'm Ashlyn.
I'm John.
I'm Saida.
And this is Lita, and we'll be covering Myasthenia Gravis. So the learning objectives for Myasthenia Gravis, first we're going to talk about the normal physiology, then the pathophysiology, the signs and symptoms, some diagnostic studies, treatment and medications, complications, and nursing diagnosis and interventions associated with Myasthenia Gravis. Myasthenia gravis is a chronic autoimmune disease that destroys, in particular, the nicotinic acetylcholine receptors, and that is found in the neuromuscular junction. And it is characterized by voluntary muscle weakness that progresses throughout the day. So voluntary muscles would be like the muscles for speech and swallowing. And just to remind you that the definition of autoimmune is basically the body is just attacking itself for no particular reason. So over here we have a picture of the neuromuscular junction, and this is basically where the entire disease process takes place. And before we talk about the pathophysiology, first I'd like to talk about the normal physiology so we can kind of compare what's normal and what's abnormal. So on the top over here we have the nerve, and then over here on the bottom we have the muscle fibers. And just to orientate ourselves, this is acetylcholine over here. And these projection things, these are called the nicotinic acetylcholine receptors. And that's basically where the acetylcholine is going to bind to. If you notice that this top right image, there's so many of this nicotinic acetylcholine receptors as compared to the bottom. It's very scarce. There's only a few. And if you can notice that there's antibodies attached to these. So not only is there only a few, it's already being, binded with something else. But anyway, so the normal physiology, what happens is that the neuron is going to receive an impulse, which will secrete a neurotransmitter called acetylcholine. The acetylcholine is going to work its way down to the receptor site. This thing is really difficult to write with, by the way, so I'm trying to draw an arrow. It's going to work its way down to the receptor site, which is the nicotinic acetylcholine receptor, and that's basically going to initiate muscle contraction. As opposed to somebody who has myasthenia gravis, this is the nerve, and here's the muscle fibers. The nerve receives an impulse. The acetylcholine is getting released. The acetylcholine is working its way down to the receptor, but it can't bind because there's already the antibodies is already binded. And not only can it not bind because it's already bound by the antibodies, there's only a few. It's very scarce. So that is the problem with acetylcholine. There is one major component missing on this slide, which I do have it in the next slide. This drawing is absolutely atrocious, but I do take credit for it. So just to reorientate ourselves, this is the nerve, this is the muscle fiber, here's the acetylcholine, here's the antibodies, and these are the nicotinic receptors. The only thing that was missing in the previous slide was the acetylcholine esterase, and this is important because there is a medication that that's used for myasthenia gravis. So the acetylcholine esterase, basically what it does is that it breaks down unused acetylcholine, and that is completely normal. That is the normal part of physiology because there's so much acetylcholine being released, it's going to bind to an empty nicotinic receptor, and whatever doesn't bind, instead of there being an accumulation, the acetylcholine esterase will break that down and kind of recycle what's not being used. But as we know with myasthenia gravis, a lot of the receptors are already being bound by antibodies. And then there's also going to be a scarce amount of nicotinic receptors to begin with. So what we're going to do for this acetylcholine esterase, we're going to try to block this. And the reason why we block it is so we can have acetylcholine readily available whenever there is a nicotinic receptor free. According to myasthenia.org, Myasthenia gravis affects approximately 36,000 to 60,000 people in the United States alone. There is a slight female predominance, and usually they get diagnosed within their 20s and their 30s, but men actually take the lead, and they can get it in their 70s and their 80s. It is unknown why some people are more predisposed to developing myasthenia gravis, but research shows that there might be a genetic component associated with obtaining this disease. As far as unusual thymus activity, if you remember, infants have a rather large thymus gland and adults have a small thymus gland, but people who have myasthenia gravis, their thymus gland tends to be abnormally large, or they might actually get a tumor on the thymus gland, which would increase the activity. The thymus controls the immune system and maintains the production of antibodies and will block acetylcholine. And in this particular disease process, it revolves around acetylcholine. Either the acetylcholine isn't reaching the receptor site or there's a decreased production of acetylcholine. So these patients might actually get their thymus removed. Other autoimmune diseases would also predispose somebody to developing myasthenia gravis. I read online that mothers can actually pass it to their unborn child, and they said after like 2 months of treatment or something, the child would be myasthenia gravis free. There are other factors which may worsen myasthenia gravis, which would be fatigue, stress, and other illnesses. This is a classic and actually said to be one of the first symptoms of myasthenia gravis. This is called ptosis, which is drooping of the eyelid, and it can either affect one eyelid or both. But notice in the picture how in the morning they can keep their eyes open, but as the day progresses in the evening, they have difficulty keeping their eye open. Again, in this picture, we can see ptosis, and we can also see something else called strabismus, which is cross eye, and basically the eye muscles become very tired that they tend to cross. 2/3 of patients with myasthenia gravis has ocular issues. So we talked about the ptosis, which is drooping of one or both eyelids. We talked about the strabismus, which is the lazy eye. They can also get double vision, also known as diplopia. It's also common for muscles responsible for speech to also be affected, which would cause dysarthria, which is unclear articulation of speech, and also hypophonia, which is soft speech, and that's also seen in Parkinson's as well. Patients may also experience difficulty swallowing and chewing. As I mentioned before, those muscle groups that they use again and again and again, they will tire out. So after rest, they can resume activities without any issues.
The diagnostics for myasthenia gravis is obviously first history and physical assessment. The next test that can be done is tinsolone test, which is a idurphonium chloride IV injection. If the muscle weakness temporarily improves, this can mean the patient has MG. Idurphonium chloride blocks an enzyme that breaks down acetylcholine, which allows the nerve endings to send signals to the muscle properly. A chest x-ray is done once MG is confirmed to assess the thymus tumors. MG single fiber test can also be done to confirm diagnosis of MG. A sterile needle electrode is inserted in the muscle, which gently contracts. A recorded analysis is done of the electrical signals in that muscle. If there are abnormalities of neuromuscular transmission, this may indicate MG. Also, a blood test is done, which is looking for abnormal antibodies that we'll talk about in the next slide. The most important lab values you're concerned with for a patient with MG is acetylcholine receptor antibodies that would be present in the blood. This can pretty much guarantee that the patient has MG. 80 to 85% test positive when they have MG. Another antibody you can look for if acetylcholine receptor antibodies are not present is an anti-MuSK antibody. 40% of MG patients test positive for this antibody.
Treatments for myasthenia gravis include drug therapy, intravenous therapy, surgery, or a combination of all three. The most common drug for myasthenia gravis is pyridostigmine, or mestinon. With only few receptor sites available for acetylcholine to bond, because the antibodies have either destroyed or are actively blocking most of the receptor sites, we need to ensure that the remaining neurotransmitters stay on the site as long as possible. Mestinon inhibits the breakdown of acetylcholine, thus prolonging the effects and improving muscular function. It is important to assess neuromuscular status before and after administration, including eye drooping, diplopia, swallowing, hand grasp, and gait. Advise patient to keep a record of condition and effects of the medication. Other medications for treating MG involve suppressing autoimmunity and limiting antibody production. This includes prednisone. However, prolonged usage can cause weight gain, infection, bone thinning, and adrenal insufficiency. Other immunosuppressants may be included to facilitate dosage lowering or elimination of prednisone altogether. However, interactions of these drugs vary from person to person and can take months to become effective. It is important for the patient and the doctor to be on the same page with treatment and to reduce risk of infection. Plasmapheresis is another treatment option for patients with MG. It involves removal of antibodies, decreasing symptoms. However, because it does not stop the body from producing more antibodies, symptom relief is temporary. Risks include a drop in blood pressure, bleeding, heart rhythm problems, or muscle cramps. Immunoglobulin therapy is used to treat those suffering from severe symptoms or myasthenia crisis. Instead of removing antibodies, immunoglobulins pooled from multiple donors are administered to the patient, modifying the immune system and resulting in decrease in symptoms. Symptom relief is short-term, and the therapy is often expensive for the patient. However, it is used until longer-acting immune therapies are effective. About half of the individuals with myasthenia gravis have some type of abnormality to the thymus. Some develop tumors or thymomas on the thymus. Because the thymus plays an important role in the production of antibodies, patients with myasthenia gravis are likely to have antibodies associated with acetylcholine. Removal of this gland, either due to the presence of a thymoma or not, reduces the symptoms of myasthenia gravis. Advances in technology have removal of the thymus gland minimally invasive. Video-assisted thymectomy is one method in which the surgeon makes a small incision in the patient's neck and uses a video endoscope, and small instruments are used to remove the thymus. Alternatively, a thoracic robot-assisted approach is used for a more complete removal, in which incisions are made on both sides of the chest. One important thing to consider when this approach is used is that the lung must be collapsed in order to get to the thymus. They will most likely have a chest tube inserted as well. Therefore, meticulous pulmonary care, such as turning, deep breathing, and coughing every 2 hours, and intensive spirometer use, is critical. The nurse also needs to monitor for bleeding at the site, daily wound care and dressing changes, pain control, ambulation, as well as chest tube care and drainage.
The two complications of myasthenia gravis are myasthenic crisis and cholinergic crisis. Pathophysiology of myasthenic crisis is low to no stimulation at the neuromuscular junction by acetylcholine, bringing about muscle weakness. Pathophysiology of cholinergic crisis is pretty much the opposite. It is caused by excessive stimulation at the neuromuscular junction, which leads to cholinergic response kicking into overdrive. When this happens, the muscle fibers are overstimulated and eventually quit responding. Myasthenic crisis can be caused by quite a few things, which I will go over in just a minute. Cholinergic crisis, on the other hand, is only caused by the patient receiving too much of their acetylcholine esterase medication. Treatment for myasthenic crisis is to give the patient more of the acetylcholine esterase medication per the physician's orders. Treatment for cholinergic crisis is to hold the acetylcholine esterase medication and administer atropine. Tensilin test is usually required to determine whether or not the patient is suffering from a myasthenic or cholinergic crisis. Endorphinium, which is an anticholinesterase inhibitor, is given for the patient intravenously, and if the patient is suffering from myasthenic crisis, they will show an improvement, but if the patient is suffering from cholinergic crisis, his or her condition will worsen. Comparing and contrasting the signs and symptoms of these complications shows us that the signs and symptoms are usually opposite of each other. For example, during myasthenic crisis, the pupils dilate, the heart rate and blood pressure increase, and the patient will suffer from bowel and bladder incontinence due to muscle weakness. But in cholinergic crisis, the pupils will constrict, the heart rate and blood pressure decrease, and abdominal cramping is present due to overstimulation of the muscle fibers. The most important symptom to be aware of for both is respiratory distress, which can lead to complete respiratory failure. So the reason I didn't cover the causes of myasthenic crisis on the chart is that there are quite a few of them, and there are certain things you need to know about each of them. The main causes of myasthenic crisis are illness, especially respiratory infections, surgery, stress, pregnancy, and quite a few medications. Respiratory infections can make breathing more difficult, making us use more muscles to breathe more frequently to get adequate oxygen. In a patient with myasthenia gravis, this can use up all the available acetylcholine in these muscles, leading to respiratory distress. Complications related to surgery have more to do with the type of anesthesia used. General anesthetics can lead to prolonged need for ventilation when it comes to patients with myasthenia gravis. All of us have experienced emotional distress at one point in our lives. Look back on that time and try to remember how tense all of your muscles felt, especially in your shoulders. In patients with MG, this can cause them to use up the available acetylcholine and put them into myasthenic crisis. There has been some correlation noted between pregnancy and exacerbation of MG. It is suggested that women wait at least 1 year before trying to become pregnant after diagnosis to reduce the risk of myasthenic crisis. 7 years after diagnosis, these risks are negligible. Corticosteroid treatments can be used to treat myasthenia gravis, but when starting a regimen, the patient runs the risk of having a myasthenic crisis episode. So the patient must be admitted to the hospital before treatment so that they can be closely monitored. The last risk for patients with MG is certain medications. These are the most common medications, but not a complete list. As you see, the list covers a wide variety of medications from antibiotics to antihypertensives to antipsychotics.
Nursing diagnosis and intervention for myasthenia gravis. Our first diagnosis is ineffective breathing pattern related to respiratory muscle weakness. As a nurse, you should monitor respiratory status of a patient and watch for signs of crisis and distress. You should assess the patient with the turning, deep breathing, and coughing at least 2 hours. You teach the patient coughing techniques, and you place the patient in semi-fowler position. This position expands the lung and elevate pressure from diaphragm. And because of our patient diagnosis, you should provide psychological support. Diagnosis is risk for aspiration related to weakness of vulvar muscle. We have to watch for signs of aspiration and dysphagia. The patient should be seated in an upright position to facilitate swallowing. You encourage patients to rest before meals to reduce muscle fatigue. Soft food is recommended. More frequent, smaller meals may be easier to handle. And tell the client to eat slowly, using small bites of food and rest between meals. Also, suction should be available at home if there is a risk of aspiration. Our third diagnosis is impaired physical mobility related to weakness of voluntary muscle. The patient's goal is the improvement of the strength of the weakened muscle. The patient should be educated about the basic fact about medication, and the time should be emphasized. The patient is encouraged to keep a diary to note the fluctuation in symptoms. You teach the patient to plan adequate rest period through the day, to wear appropriate shoes to minimize injury, and to eliminate factors which will cause elevation of the symptoms, like emotional upset and respiratory infection and demanding physical activities.